have a very full agenda for this afternoon, so I'm going to be very brief. And I'm going to talk about two things. One is I wanted to update you on the activities of the Johns Hopkins Vaccine Initiative. And then I'm going to say a little bit about our theme for this year's Vaccine Day, which is Vaccines to Prevent Pneumonia. So I hope by now most of you are familiar with the Johns Hopkins Vaccine Initiative, or the JHVI as we call it. This is a program of the Bloomberg School of Public Health. It's a year old, a year and a month old. It was launched in 2008 to promote collaborative and interdisciplinary vaccine research, education, and implementation efforts to improve health worldwide. That is our mission statement. Our goal internally was really to get our very expert faculty and vaccine research, faculty, staff, and students to work together more collaboratively. And so we have 33 faculty who are affiliated with the JHVI. And each of them are accomplished vaccine researchers in their own right. And I don't have time today to talk about the accomplishments of individual faculty of the past year. This has been actually a pretty extraordinary year, I think, both in terms of publications of vaccine research and in acquisition of new grants for vaccine research. But you'll get a sense of some of that when you see our poster session later this afternoon. I will, though, talk a bit about our accomplishments in JHVI. The first is Vaccine Day, which I hope will speak for itself. The second is our SPARK program, which some of you may be familiar with. This is a program that we have for Hopkins faculty, School of Public Health faculty. Small grants really meant to encourage faculty either to provide unique educational opportunities or unique sessions that will enhance collaboration. So small bits of funding that might be used to bring a guest speaker or to host a colloquium, that sort of thing. And you can learn more about those if you go to our website, listed at the bottom of the page. I'm going to spend a couple of extra minutes talking about two new things for this coming year. One is our Human Vaccine Research Database, and the other is our student internships at WHO. So the Human Vaccine Research Database, we really started thinking about this just about this time last year. And it was really sparked by both faculty within the school and individuals from outside the school who said, you know, we have no way of knowing how many field trials have ever been done or done in the recent past by, you know, people doing vaccine research at the school, or how many studies have been done under a given sponsor, or how many studies of vaccines for a particular pathogen have been done. There's no place where that data was collected and easily accessible. So we decided to take it upon ourselves to do that. What we decided to do is go through the SPH IRB database, and I have to, we owe a debt of gratitude to Joan Pettit and to her colleagues in the IRB office who allowed us that access. And we collected data. We initially identified projects from 28 faculty, 200 plus projects. And this also involved a lot of, after identifying those individual projects, a lot of face-to-face interviews. And for those of you who have participated in that process, I'm grateful, and also grateful to Levita Stewart, who was actually the interviewer of all of you. We still have a few to go. We're planning to launch by the end of 2009, and we're planning to update this yearly. And I just wanted to give you a sense of what this might look like. The output may not be identical to this. We're still tweaking what the pages will look like. But you'd be able to do a basic search, and it's a sort of, this is just supposed to indicate that it's a smart kind of a fill-in. So if you type the first few letters, it will give you some suggestions. Or you could do an advanced search. So you'd be able to search by pathogen, by product name, or trade name, or sponsor, the type of vaccine or the type of study, et cetera. The search results page will then give you a list of these various studies. You can sort them by the same parameters that you would do the advanced search by. And you can also drill down and learn more about an individual project. This is an example. And it would link you also to the clinicaltrials.gov number, to any publications if there are publications. So that's this project, and we hope that it will really be widely used both by people within the school and people outside of the school. So the other thing I just wanted to mention is what we're calling the JHVI VIEW program, the Vaccine Internship Experience at WHO. This is a new program, brand new. These will be 12 to 24-week funded internships in Geneva for School of Public Health students with mentors in the Department of Immunization, Vaccines, and Biologicals. We'll give preference to students who have taken vaccine courses at the School of Public Health, and if you don't, I hope all of you students know which courses are vaccine courses. If you don't, they're all listed on our website. We are planning that announcements of the projects will be done in January. Applications will probably be due in February, and the first internships will start in September. And again, you can read more about this at our website. So before I talk about vaccines to prevent pneumonia, I actually need to thank a lot of people. I wanted to first mention people from the Center for Immunization Research who've done a huge amount of work in getting Vaccine Day up and going, and those are Amber Cox, Levita Stewart, and Jason Morcell. And Levita, as I mentioned, is also our very hard worker on the vaccine database. Christina Carr, Jeff Dubnow, and Monique Forbes Dickerson in the Office of External Affairs. And because they don't get mentioned enough, I actually wanted to say something in particular about our steering committee, Neil, Oren, Kate, and Fidel. These are 4 incredibly busy faculty members who volunteer their time every month or so to come and meet with me and think about what we might do to make vaccine research or policy work more vibrant at our school. And I very much appreciate their wisdom and their leadership, and they're great people to work with. So you're going to hear, I'm just introducing, you're going to hear a lot more about this topic all afternoon long. The theme for Vaccine Day is Injecting Hope, How Vaccines Save Children from Pneumonia. And why did we pick this topic? Why would we focus on vaccines to prevent pneumonia? Well, I'll start you off with just a few reasons. There are many, many reasons, but these are just some to start and think about. One is that pneumonia is a major killer of children. It kills 4 million children a year, 2 million under the age of 5. The second is that I know that the H1N1 pandemic is on all of our minds, and that pandemic will only increase the global burden of pneumonia. And it's also likely that, as with the other pathogens that cause pneumonia, H1N1 influenza is likely to have a disproportionate impact in resource-poor settings. And the third is that really our people at the School of Public Health are leaders in assessing the global burden of pneumonia, in evaluating and deploying vaccines to prevent pneumonia, in determining the etiologies of pneumonia. And of course, they're also the leaders when it comes to World Pneumonia Day, which I hope all of you know about, but which is November 2nd. And I think this Vaccine Day is a wonderful event in itself, but I think it's also a bit of a prequel to World Pneumonia Day. So that's all I have to tell you. I'm next going to introduce our Dean, Mike Clagg, who is going to introduce our keynote speaker, Brian Greenwood. Mike?
Thanks, Ruth. And you know, as an administrator, these kinds of issues you're tackling with the database are things that we need. You know, and I was always frustrated when I headed the IRBs in the School of Medicine, and people would say to me, "So how many people are enrolled in clinical trials at Hopkins?" I said, "Gee, we have no idea. You know, how many?" So it's great to see. It'll be a big help. And thank you for allowing me to introduce our speaker today, Brian Greenwood. And in your brochure for today, the program, there's a description of Brian and his accomplishments, and I'll try not to repeat that, but I have to tell you, he's a hard man to introduce because he's done so many things and has had such an impact. He is British. He graduated from the University of Cambridge and then trained in medicine, later trained in clinical immunology. And he has devoted his career to improving health of people of Africa. He went to Nigeria after his training, and he was instrumental in establishing a medical school there. And then he led the MRC laboratories for 15 years in the Gambia, where he developed a robust research program. And what's unusual about Brian, in addition to the fact that, as those of you who know him know, he's an incredible person and a wonderful colleague, is that he has made seminal contributions in multiple areas of infectious diseases. Malaria, yesterday he spent the day with our malaria staff, but he's done studies on pathogenesis, genetic susceptibility, chemoprophylaxis, and treatment regimens, and he was the first to demonstrate that insecticide-treated bed nets had a tremendous efficacy in reducing the incidence of malaria in children. He's conducted landmark trials of vaccines in Africa, and he currently directs the Malaria Capacity Development Consortium, which aims to increase research capacity in Africa. He's also had similar kinds of contributions in meningococcal disease, where he conducted one of the first efficacy studies of meningococcal polysaccharide vaccines in Africa, and has done a variety of other things there. And lastly, and the reason that he's the keynote speaker today, is he's done incredible work in HIV and pneumococcal disease, with landmark studies being conducted of the vaccines to prevent these diseases in African children. He first used the concept of probe studies, where for diseases as we just heard about, which are syndromic diseases like pneumonia, where it's difficult to know what the pathogen is, that using trials of the vaccine to look at what the decrease in incidence of disease was, and then get a sense in the community of the burden of that disease. And near and dear to our heart, in everything he does in doing high-quality research and making contributions, he is concerned about capacity building and improving the ability of countries to do their own research and improve the health of their own population. He's won many awards, has many letters after his name. And I'll just mention one, and that's the Hideo Noguchi Africa Prize in 2006, to honor individuals with outstanding achievements in combating various infectious diseases in Africa and in establishing innovative medical service systems. So I think Brian is somebody who really epitomizes the motto of our school of protecting health, saving lives, millions at a time, and it's really a pleasure to have you here today, Brian. So.
Put the microphone on. That's just. Okay, thank you very much. Thank you very much, Dean, for those kind words. That's very generous, and I'm very honoured to have the chance to come and talk to you today on this very important day. And I really have admiration for what's been done here. As you know, London School and Johns Hopkins are sort of friendly rivals, but they are rivals. And when I first came back to work there, I tried to set up a vaccine centre like this in a London school, and it didn't work. It has worked for malaria, where we have quite a vibrant centre, perhaps because there wasn't the critical mass that you have here today, and it's really exciting to see. This is sort of envisions what might happen, so congratulations to Ruth and everybody who has achieved that. And I think, this is a very important way of working together that is happening increasingly, and this is clearly working very well here at the moment. So I'm going to talk about preventing pneumonia in Africa. And it was difficult. This is a difficult sort of lecture to give because I know there's quite a mixed group of people here. So please bear with me, those of you who think I'm talking down to you. I know that you know a lot of this. But I will try to cover a fairly broad range of topics. And this is what I'm going to do. It's going to say a little bit about about me. As a well-brought-up Englishman, you're not meant to do that. It's rather actually bad form to talk about yourself. But Ruth thought it might be quite interesting, particularly the younger ones of the students are here, to hear a little bit how I come to be somebody born in the UK, come to be talking in Johns Hopkins about preventing vaccines in African children. And I think the message, perhaps some of you take, is to follow what you want to do. I mean, it's been a slightly funny story for me, but I think I know I've had a very rewarding life by following things I wanted to do and not being stuck in a particular pathway. So I said a little bit about how I got interested in pneumonia, a little bit about the burden of acute pneumonia in the developing world, an area which Johns Hopkins made important contributions, a little bit more generally about preventing pneumonia in children in the developing world so that we can put vaccines into their context. And then the main part of the talk about vaccinations and what happens next. And I won't be talking about tuberculosis, which obviously is a very important cause of pneumonia and sometimes can get mixed up with acute pneumonia in children. It can present in the same way as bacterial pneumonias, but that's a huge topic. Maybe I suspect one you might have for a whole vaccine day on its own one day. And my focus will be on Africa, because that's where my experience has been. So the story really starts in 1965, when I trained as an adult physician, went to work after 2 or 3 years in the UK in this hospital here in Ibadan in Nigeria. And at that time, there were 2 very fine hospitals in Africa, this one here and one at Makerere, some of you will know, in Kampala. And this hospital was of the standard of any of the best ones in Europe, certainly at that time. And my ward was somewhere, I think it was somewhere around here. We did ward rounds with 2 consultants, 3 senior registrars, 2 registrars, 3 interns for about 30 patients. It was just like it would have been happening in Johns Hopkins. And shortly after that, the Nigerian Civil War started, the Biafran War started. Many of the Nigerian staff came from the eastern part of Nigeria, from Biafra, and left the hospital. And suddenly I was confronted with being one of 6 or 8 doctors in a ward of 30 patients with this. Everybody had to put their hands to what was going on, the general outpatients, and very rapidly, I've never been a proper pediatrician, but this was a crash course in thing, and I'm sure that among these children here in the general outpatients, you can see, I'm sure that there were some who had pneumonia. So, as the Dean has said, a few years after the war had stopped, I went to northern Nigeria to help start a new medical school, Ahmadu Bello University. Really rather different scenery from the beautiful University College Hospital. And this was a district hospital, typical of many in Africa. The pediatric ward looked like that. And again, we're confronted with lots of people with malaria. It was a rather remarkable place. And the person who was professor of medicine here is somebody called Eldred Parry. Some of you may have heard of. He wrote the first textbook of medicine for medical students in Africa, and he really put his imprint on a lot of people. And one of the things, and as an example of the sort of things he did, that even if you were a consultant in charge of your ward, he made you take one of your patients home each week to the community with the students, and which was very innovative to think of the idea about that. Looking back also at his book, which he wrote with my colleague Hilton Whittle, who's there, the first one I think is on sort of social aspects of medicine, the next one is on agriculture, the next one is on climate, which in 1970 was really very forward-looking about how all these things interact in the care of patients. So I was very fortunate to work in with a very able group of people there. Some of the people you may know, one is Professor Tugwell here, who's a famous epidemiologist in Canada now. This is David Worrell, who became Professor of Tropical Medicine in Oxford. That's Andrew Tompkins, who became a Professor of International Child Health at Great Ormond Street in London. We had fantastic staff, but not much of a lab. This was our lab. And we were discussing equipment and things like that. We were fortunate that you probably can't see this very well, but we were quite well provided by the Medical Research Council and the Wellcome Trust, and that's me with my fraction collector, which I was inordinately proud of at that time, which was rather like having a sequencer now to do that. And we were able to do quite good research, I think, in these rather limited physical surroundings. As long as you have the equipment and you have the people, perhaps the building isn't quite so critical. So some people ask me, well, how how did I come to work on malaria and pneumonia? And I think it's pretty obvious when you think about seasonality. And in that part of Africa, in the sub-Sahel, you have these extremes of season, going from the dry season, where it's very, very hot and dusty, it doesn't rain at all, to the wet season, which may be very wet indeed for 3 months. And of course, the malaria parasite likes this time, the pneumonia, the bacterial infections, the meningitis, and the pneumonias at this time. So it seemed obvious that really it wasn't a conscious decision. What did we do? Just shut down our lab bed and then wait till the next rainy season came, or did we do something else? And that was really how we got involved in that. And last week I was visiting the CERMES lab in Niamey in Niger, and it's interesting, which has been going now for about 30 or 40 years. Their 2 main diseases that they study are meningococcal disease and malaria. So it's a sort of logical thing to do in that part of Africa where these are the 2 dominant diseases. And then in 1980, as the Dean has said, I went to the Gambia. We set up this field station at Farafeni, which very sadly has just been closed by the MRC. And one of the first things we did there was really to find out what actually the children dying of in this community. A lot of the research up to that time in the MRC labs had been rather hospital, clinical based. And so using the post-mortem questionnaire technique, which was just coming into use there, we went out into the community, asked the mothers, asked the families, well, what did your child die of? And the results were rather of a shock. At that time, following on the work in Bangladesh and IDDCRB and the ORS and so on, there was a lot of interest, quite rightly so, in diarrheal diseases. And I certainly thought that when we knew malaria was a problem there, I thought gastroenteritis would have filled at least this part of the pie. And it really was a surprise to find that it seemed that pneumonia was probably as common as, or more important, as a cause of childhood death and malaria. And to their credit, the Ministry of Health in the Gambia, when we presented these data at one of the meetings, they said, well, I think you better do something about studying pneumonia. That was really coming from this original postmortem questionnaire, was some of the work that followed after that. Now we know now that when we look globally, that pattern is not too uncommon. Ruth showed you before, the pneumonia, a major cause of childhood deaths. If we did it, this is for the world as a whole, if we did this for Africa, we'd find actually the pie was about equally divided between malaria and pneumonia. But because you have China, India, some of the Mongolia and countries like that, which don't have any or very little malaria, if you look at the global picture, then pneumonia becomes the biggest cause of childhood death. Diarrhea is still a very important one, but this had been very considerably neglected. And what we had, this is the deaths, yes, just to say this is just a disease of young children, 80%, when we did those post-mortem questionnaires, 86% less than under 2. So what was the cause of these children were dying in the community, often never coming into hospital, not being seen? What was the cause of these respiratory deaths? Well, that was pretty difficult. I mean, all we could do then was look at the children who did actually make it into hospital and assume that they were representative of what was happening in the community at large. And I think we'll probably come up later in the discussion today, diagnosing the cause of pneumonia in young children is very difficult. The only real tool we have to do is blood culture, and that's a very insensitive test with perhaps giving you 10 or 20% that you can do routinely. So some quite brave people, really starting in the 1930s, actually took a much more direct approach and actually stuck a needle, small fine needle, into the area of consolidation in the lung, took some of the fluid out and saw what was actually causing the pneumonia there. And that's not something you would do just out in the district dispensary, but it is done by the right people under the right conditions. It is a safe investigation to do. And at about this time, Dr. Shan gathered together the data that was then available on lung aspirate studies, see what were the causes, and these 2 bacteria, which we'll hear more about much more today, I think, came out from those studies as the biggest causes of pneumonia. And then when we repeated some of these studies in the Gambia in the hospital patients, indeed the picture was much the same. It looked very like this global pattern of Pneumococcus haemophilus and some other bacteria as well. But now we know a little bit more about the burden, and thanks to a recent study we've just heard mentioned, published in The Lancet from Kate O'Brien and others from Johns Hopkins here, who've undertaken a really very detailed analysis of all the information that we have about what is the actual burden caused by these two bacteria, something we really could only guess at a few years ago. And it's pretty clear now that the pneumococcus is responsible for about both pneumonia and meningitis, responsible for 750,000 deaths, and Haemophilus still something like 1/3 deaths. So these two bacteria are killing about 1 million children every year, nearly all of those in developing country situations. And in these papers, they've produced some very nice maps showing what the incidence rate is in different parts of the world. And red is bad. Here, light green is good, and you can see there's a focus here in Africa. I think this is Afghanistan there. When we look at the map for HIB, that's for pneumococcal disease, the same thing. And it just struck me that actually in preparing this talk, that we think of pneumonia and Haemophilus disease really as diseases of cold countries, of the winter and the cold. But actually what has happened now is that these have become tropical diseases. I mean, it is, and of course the reason for this is that tropics is linked to poverty, and these are probably diseases of poverty. But it really is rather striking that a disease that we associate with sort of winter and so on has actually now, its main focus is in the hottest parts of the world and in the center of Africa. And in these very nice studies, they've also broke things down by country, and I think this is these are very salutary slides of people who are thinking about prevention, and this shows the proportion of the numbers of cases in individual countries with pneumococcal disease, with Hib disease, not India and China coming up here. And this is obviously quite different from malaria, where there is a big difference from malaria. Hib again, India, China, Nigeria, Ethiopia, and so on. And I think this is a very important point to remember, that it's very easy, or relatively easy, in a nice little country like the Gambia to go and do something, or perhaps in Uganda or Rwanda, which we may hear about later. If you don't tackle these big countries where the major burden is, we're not going to see a major effect on the overall global burden. So I think these are very important pictures from that point of view. So here we have a disease that's killing 1 million children, well, two diseases, pneumonia killing 4 million children, two specific diseases killing 1 million children every year, and yet really very few people pay much attention to this. If we were to go out in the streets in London and ask people about what's killing children in Africa, quite a lot of people would say malaria now. That message has got out, that malaria is still a major problem. I'm sure nobody would know, of the general public, or hardly anybody would know that pneumonia is as big a killer in Africa as malaria is. And I think it is interesting just to think a little bit about why that has been the case. And I mean, obviously, one issue is that this is a disease of poor children. It's the poorest of the poor. I mean, the attack rates in poor countries are highest in the most deprived communities. So they don't have the advocates there to talk for them. It has several causes. We can sort of have nice pictures of malaria parasites and mosquitoes and things which people can focus on. It's slightly more difficult when you've got such a diverse number of organisms causing this condition. There has been, until fairly recently, a perceived lack of any idea that we could do anything about this. I mean, bed nets, malaria is a nice obvious story that people can understand. This is a more difficult one to sell. And I have to say, I think creation of the Global Fund really has harmed this disease. If malaria was lucky, as I understand from people who know that, it just crept in at the last minute. I mean, it was to be HIV and tuberculosis, and that has had a major effect. And not by any intent of the people who were doing this, it has actually resulted in a relative neglect of diarrheal diseases and pneumonia. And if we had a global fund for HIV, tuberculosis, malaria, diarrhea, and pneumonia, I think we would not perhaps be in the parlous situation that's happening now. And there has, until recently, been a lack of advocates. Malaria has had some very strong advocates. That's not been the case for pneumonia. But it's not all gloom. I mean, things are happening. And we heard a little bit about the pneumo and the Hib. I'll say a little bit about that later on, and I'm sure that will come up later in the discussion. They've done a really excellent job in pushing in, but for one particular prevention against pneumonia, pneumococcal and Hib vaccines. And the advanced market commitment, again, may come up in the discussions, it has provided a means for which, for some of the poorest countries, these new vaccines can be financed. I'll say a little bit about GAP, and then we've already heard mention of the World Pneumonia Day, which is another excellent initiative that's coming along to try to do that. So GAP is Global Action Plan for the Prevention and Control of Pneumonia, which was formed about 2 or 3 years ago. Some of it, they produced this bulletin in WHO, which is quite a useful summary of what's known about ways of preventing pneumonia, including vaccination. But I have to say, this is a very poorly resourced organization for something that's trying to be a powerful advocate to really get things going. It is just completely under-resourced for doing that. And this has been one of the problems, as mentioned yesterday in talking about malaria, that the leadership that WHO is providing in the malaria field has gone down substantially. They're not providing the leadership, in my view, that they should be doing for this problem, but they don't have the resources to do it. So it's not the fault of the people who are there who are trying their best. They just do not have the resources to do that. But anyhow, this is a welcome step forward. And these are the conclusions of the GAP committee and what is presented in that WHO bulletin of the things that I won't bother to read them out. You can read those, the things that they recommend that we can do for preventing pneumonia. And one of those is increase the uptake of vaccination. But there are other things as well that we will come back to at the end. So the rest of my talk, I'm going to be talking of my real topic, which I should have been with a long introduction, vaccination against pneumonia, and why I've always been a fan of vaccination, and why have I been a fan of vaccination as a control tool, and some of the reasons are listed here. I mean, I think a really key thing is in poorly resourced countries, vaccination can happen when the child is well, and to some extent the family have the time. They can choose. If they miss the clinic 1 week, well, it's bad, but they can go back to the clinic next week. When their child is sick with pneumonia or malaria, they have to get to the clinic in a few hours, and there may not be the transport to do that, or they may not have the money at that particular time. So that's a really important thing. And I think, and for this, the reason that actually vaccination does help in equity issues, and that when situations you're relying on access to medical care and treatment as your means of disease control, that favors the rich who have the resources to do that. If you have a free EPI program, it is more likely to get out into the poor communities as well. A few contacts can prevent lifelong protection. Nearly all the studies of the vaccines that we've used so far have shown that they're highly cost effective. And most countries have some sort of effective EPI program. Even when their curative health system may be a very parlous state, they do manage to deliver the routine vaccines, either through fixed clinics or sometimes in some situations through mass vaccination campaigns. So vaccines have a lot going for them as a control tool for malaria. So the first step, if we're going to use vaccines, is what's the cause? And we probably will want to talk a little bit more about diagnosis in the discussion. I mean, I mentioned the 2 bacteria, but it's more complicated than that, and that is one of the problems. And this is just a list we saw before. This is the previous one of the bacteria causing pneumonia, but we have viruses causing pneumonia. In the case of HIV, we have pneumocystis, which I think is a fungus. Now, a very important cause of pneumonia in young infants, say, like in South Africa, to do that. So we have a complexity of that, and we have really, this makes it much more difficult than in thinking about vaccination as your primary control tool. So let's talk a little bit about the viral vaccines first, and I think we have a very effective vaccine against pneumonia in measles vaccine. And if some of you had come with me in the 1970s into that ward I showed you in Zaria, and we looked at the pediatric patients in the ward there, at least half the children in the ward would have had the complications of measles, and some of them been malnutrition with kwashiorkor. Frequently there were children with pneumonia, and that was it was a bit like going around Soweto, going around the Baragwanath Hospital, seeing the impact of HIV now on pediatric illness. Measles was like that when it was raging without being controlled by vaccination. So we have an example of a very, very effective anti-pneumonia vaccine in measles. And it's been a dramatic success. This is the deaths from measles in Africa, coming right the way down here. We have an expert here who might want to talk about this later. But the battle is not over with measles, and we know it bounces back, and this is from a newspaper in the UK, and a big increase. I mean, people got lazy. because of the scare about the MMR vaccine, the vaccination rate fell off. It didn't fall off disastrously, but it fell off an outbreak of measles. And I think there's been an outbreak in Burkina Faso. We had a big outbreak there, something completely sort of unexpectedly, and coverage doing reasonably well. So we have to keep, I mean, if this is going to be sustained, you can't just sort of shut down and think, well, we've done this now. That's got to be sustained unless we get measles eradication. So what about the other viruses? RSV, we have an expert here, and so if you have questions about RSV, there's somebody to ask about that, but clearly that is an important cause of pediatric respiratory infections and sometimes pneumonia. It has a rather unfortunate history because some of the first vaccines that were made, the killed vaccines, actually made the children worse, and I think there were even some deaths as a result of vaccinations. That made people very scared, really, about the development of RSV vaccines, and that's been very slow. But there are things happening, and I'm sure Dr. Karen will be able to, if you're interested in that, will be able to tell you more about what's happening in that field. And then a new kid on the block, and I think, as Ruth mentioned, the problem is seen at the moment as Europe and the United States really worrying. I think perhaps worrying more here than actually in the UK is the impression I get at the moment. But I think it's very salutary to remember that where most people died in the 1918 epidemic were in the developing countries, in India, Africa, and so on. We don't know the exact numbers, but the biggest burden was there. So if we're thinking about Africa, we shouldn't be forgetting H1N1, I mean, because the impact there could be at least as great or even bigger than what it would be in the industrialized countries. And I think even before this happened, there was a beginning to be a sort of feeling, well, maybe influenza is actually neglected as a cause of illness, serious illness in young children in the developing world. And this was an interesting study that was reported a couple of years ago by a group led in Bangladesh by Mark Steinhoff, which showed that vaccinating the mothers against influenza protected the babies because of the antibody that had gone across the placenta. And to me, the interesting thing about this was how many cases of influenza there were in these young infants who were presenting in Bangladesh. So maybe influenza is an important cause that we could prevent pneumonia by vaccination, even outside the H1N1 pandemic situation. And it has been suggested that one of the major reasons why people did die after the 1918 epidemic was because they got secondary bacterial pneumonia, and particularly pneumococcal pneumonia. And my father had the 1918 flu. He must have been about 8 then, or 10, and he had the scar on the side of his chest where he had his empyema when he must have had either staphylococcal or pneumococcal pneumonia after that. And of course, before antibiotics, he was lucky to survive that. So there is work going on. Some of you may have heard Keith Klugman talk about this. He had looked through all the records of the military that they have in the United States. And they had blood cultures and post-mortem studies. And a lot of the ones who died of pneumococcal disease. And another study is going on in Australia, which has found exactly the same thing in the military there. In Australia, it was the same thing. So this is another area where there may be a link, that if this is whether perhaps pneumococcal vaccines might have a role in the control of influenza as well. Okay, so let's go on to our two big bacteria, the two main bacterial causes, Haemophilus streptococcus pneumoniae. A slide here just for some of you who are not familiar with the vaccines. I apologize to the people who know this very well. Against these bacteria with a capsule, we can make different sorts of vaccines. We can make one that comes from actually the polysaccharide itself, shown here. Or we can join that up with a protein, which is not anything to do with the pneumococcus or the Haemophilus, to make what we call a conjugate vaccine. And then we can actually make a vaccine out of one of the protein components of the bacteria as well. And all three of those sorts of vaccines have been used. They have different properties. The polysaccharide ones are generally the least satisfactory. They're not very immunogenic in young children. If we're thinking about pneumonia, that's obviously a big problem. You don't get immunological memory, so that if you are vaccinated a second time, you don't get a booster effect, and they don't have an effect on nasopharyngeal carriage, where these bacteria are living and being transmitted from one person to the other. And the conjugate vaccines are much better in all of those respects. I think we used to think that the main reason why the conjugate vaccines were better, and certainly what I thought was that they induced immunological memory. But we know now from experience in the UK, where the UK didn't introduce a booster dose of the Hib vaccine, that is not the case. Those children had immunological memory, but they were still not protected. And so I think a really important thing, I think people are thinking more, especially about pneumococcus and meningococcus, is that it is stopping carriage that makes these vaccines much better vaccines than the polysaccharides. So what about Hib? Almost gone. I'm sure many interns and residents now will not see a case of Hib meningitis. So it's nearly gone. What's happening in developing world? Well, that's interesting because as the Dean mentioned, that there is a difference in developing countries in the epidemiology of Hib. In industrialized countries, the predominant form is meningitis, and pneumonia is uncommon, and this condition of epiglottitis, inflammation of the epiglottis, is a very dangerous, nasty condition, used to be relatively common, a serious emergency. I've never seen that. I have actually once or twice, but it wasn't due to Hib in Africa. And the predominant form in Africa is pneumonia, and meningitis about the same. And so Hib vaccines have the potential for being an anti-pneumonia vaccine, a much more powerful one in developing countries than they do in the industrial world. But it was quite difficult to prove that until we did a trial in the Gambia led by Kim Mulholland, some of you will know. And this vaccine was known to work. It had been shown to work in the United States and elsewhere, so we knew that it would work. And then we looked to see what happened against pneumonia. And as the pneumonia got worse, the efficacy of the vaccine improved. So it was pretty good evidence that a lot of these really severe pneumonias in these young children were due to Hib, and we had a very effective vaccine there for preventing them. And when this vaccine was introduced in the Gambia was the first country to introduce the national immunization program. This was the Hib trial, when half the people in the area were being vaccinated, and the disease, this is meningitis, but all the other forms of the disease went away. And that has stayed away. And there was a little blip somewhere about here, but last year I think there were 2 or 3 cases who had actually been vaccinated. So there is a little bit of vaccine failure. But it's been incredibly successful, and this has been shown in other countries in Africa, in Kenya and Malawi as well. And I think the critical thing was this is the nasopharyngeal carriage, the number of children carrying the Hib in their throat, very high, 10 to 20%. At the time of the Hib vaccine trial, it's almost disappeared. So this vaccine, this organism has largely gone. So what's happening in the developing world? Well, thanks to the Hib initiative, there has been a real push to get this vaccine out just in the last few years. And I think many of the countries, I think we have here 5 out of Americas, 35 out of 6 countries in Africa and so on, have actually either introduced that vaccine or made a commitment to do so. So a lot of progress, 61 of 72 Gavi countries have introduced the vaccine. Are we on the way to elimination? Well, it's not a completely crazy idea for this. I think that the message has come through that biologically this is not a very successful organism. And in the Gambia, vaccine coverage is probably only 70%, and yet in spite of that, the disease has almost disappeared. And this suggests that actually it is on the margin a little bit. It doesn't have a very high reproductive rate, and it may be very easy to knock. We don't know that there are any animal vectors, so potentially this is a disease that could be eliminated. Okay, so let's move to the pneumococcus, the other even bigger cause of pneumonia. We've had this vaccine dependent on the capsula, made from the capsular polysaccharide for a long time. It's used in adults, but it's not very effective against pneumonia, even in old people. There's argument, people write learned reviews and so on and things, but the message is really clear. It does prevent bloodstream infections, but probably not pneumonia. It doesn't work in very young children, as the group we're interested in, and there was one study in Papua New Guinea which suggested it might work, but this was really not a vaccine that was going to have an impact on pneumonia in children. But making a conjugate, like as I described at the beginning, by linking the polysaccharides to a protein, made a much more effective vaccine, and the results, as you will all know, I'm sure, in the United States have been absolutely dramatic, that the pneumococcal disease in the young ones has gone away. It's also gone away in their grandparents and gone away in young adults as well because of reducing carriage and thus reducing infection. Does it work in the developing world? Yes, it does. The results from South Africa of a trial, 83% protection against pneumococcal disease, 20% protection against pneumonia, and more if one looks at severe pneumonia. HIV positive is not quite such a high level of protection, but still it still works. And one thing to remember is that the risk in these people is about 20 times higher than the others. So if you had only a limited amount of vaccine, I would give it to the HIV positives, not to the HIV negatives, because even though the efficacy is not as high. And in the Gambia here at Bassi, suffering its one flood in 50 years in the middle of this trial, just showing how things can conspire against you. Sometimes, again, was highly effective, sort of 37%, I think, protection against pneumonia, and in this case, an effect on mortality and hospital admissions that was statistically significant. So this appears to be a very exciting vaccine. It's a vaccine that works. It works in a developing country setting. It is one that could be a major preventer of pneumonia. But unfortunately, there are still some problems. I mean, one is getting this vaccine out there into the it is relatively expensive, and there has the Pneumo ADIP has done a very good job in doing that. And 2 countries now in Africa have actually introduced into their routine EPI program, and the Advanced Market Commitment, again, which will probably come up in the discussions, has provided a means of which you can these vaccines can be afforded. But we have a biological problem here, not just the logistic financial ones, in that we have more than 80 different types of pneumococci. And when you get rid of a limited number of them in the nasopharynx with your vaccine, the other ones can come back and fill that space. And we don't really understand the biology of that and why that is happening in some places and not in others. And in Europe, there's been a much bigger problem than there has been in the United States, where this has happened, but not to the same extent. And this is some data. You can get it off the website of the Health Protection Agency in the UK. I haven't seen this presented anywhere in a published form, but what this shows is that the number of cases, these scales are actually the same. It's not a smaller scale. So if you look here, this line is from 2003, 2004 down to here. The vaccine serotypes have gone, but the non-vaccine ones have come dramatically increased and have nearly taken away the whole benefit. And I was told by somebody when I was in Miami last week that in Belgium it's taken away the whole benefit. So there is a biological problem here with Prevnar. So what could we do about that? Well, there are 2 things. One is to increase the number of components of the vaccine so that we cover some of the others, and there are 2 new vaccines on their way which will do that. But I think that may be just pushing things a little bit further. There are another 70 different serotypes, and they may not be quite so biologically fit as some of the ones there. But, I mean, I don't think that problem is going to go away. And the other way of tackling that is to go back to, if you remember back to my diagram, is to take one of the proteins of the pneumococcus, which is common to all the different serotypes, and use that as a vaccine. And there is some work going on that, being funded by PATH, and we're about to start a trial next year in the Gambia with a protein conjugate combined vaccine that they've been developing. So that's where we are. We have our viral vaccines. We haven't yet got one with RSV. We have pretty effective vaccines against the 2 main bacteria. What's going to happen next? Well, I think a really key thing is to find out, is to go back again to some of those etiology studies and find out what happens, what is causing pneumonia in children, particularly in the developing world, in an area that's free of Hib and pneumococcus, the 2 big vaccines that we did that. And that's going to need new diagnostics, and I know there are new etiological studies being planned that will have more sophisticated tools than we had when the only thing we could do was lung aspirate, which was not a really very nice thing to be doing. So that will be really important. And when you look at what might be on that list, it's a big list of organisms that are known to cause pneumonia that are not covered by the existing vaccines. And there may be others down here that we haven't actually found. And the issue then is really, if we're thinking pneumonia and vaccination, will vaccination be a feasible option against those? Well, I think, as we mentioned, we should get vaccines against the influenza and RSV. Staphylococcus aureus, possibly, our people are working on that seriously, and non-typhoidal salmonella, this funny group of organisms that are very common in people who've had malaria or have HIV, and there is work going on vaccines to develop those. Chlamydia, not so sure. But just to remind you, this was the chronology of the studies on the pneumococcal vaccine in the Gambia, from the beginning of the first studies showing that this was an important disease to the time of national immunization, 20 years. So if we're going to be routinely immunizing with a non-typhoidal salmonella vaccine, we should be starting on that now if we think that's going to be a problem. This process takes a very long time. So what happens if we don't have a vaccine? Well, if we go back to the GAP study, there are lots of things we can do to prevent children from dying from pneumonia, even if we can't do it through vaccination. We can make sure that they get treatment when they're sick, get access to the right drugs, and some of these other prevention. We have some advocates for some of these here of nutritional things and things we can do to reduce that. So vaccination is not going to be the only way of preventing pneumonia. It's going to be a very, very important one, but we will still have to keep up with some of these other general measures. So I've come to the end of my talk. A talk like this, you can't really give acknowledgements to everybody. I mean, had the privilege, that's one of the nice things of my career, I've had the privilege to work with so many able and nice people to do so. But of course, none of this would happen without people making the commitment to these large trials. And these can sometimes be quite demanding on people. Fantastic cooperation we've always had from the people who've helped to produce the results, which enabled us to go forward with sound public health recommendations. So thank you.
So thank you, Brian, for a wonderful talk. We have some time for questions from the audience. Yes, Matu.
So, Brian, great talk. Thanks so much. I have one comment. Just an update on the HIP coverage and Gavi countries.
Yes.
Follow up for
72.
Somalia is the only one.
Okay. Yeah. And is that actually happening or a commitment? Yeah, commitment.
As far as the HIP you mentioned about the booster dose.
Yeah.
Booster dose and most developing countries are not done with the booster
No.
dose now. So there's just some new thoughts about how we could change the schedule.
Yeah.
And secondly, the pneumococcal conjugate vaccines is not an ultimate answer, as you all know. What do you think about the possibility of using perhaps a pneumolysinoid as a carrier protein and creating a conjugate vaccine?
Yeah.
That's all.
Well, I think, yeah, the HIB, I mean, that's good news about the HIB vax, but there is a difference between, well, the question was, well, Matteo just said that the number of countries that have made a commitment now to HIB implementation in the Gavi countries is now nearly the whole lot. The problem area from that, I think, is the middle-income countries then, isn't it? That's going to be the ones who are not eligible for Gavi. I think Philippines is just not outside that. So they're the countries who have a GDP of $1,500 per person. I mean, they're going to find it difficult, and they're not going to get the vaccine through Gavi. But I mean, that's a huge success. I mean, so that's going to have a big impact. The pneumococcal vaccine you mentioned about the idea of using a pneumococcal protein as the carrier protein. I mean, that certainly could be done. The vaccine that GSK is making, it has a synthetic protein which has got two components of it, one of which is the pneumolysine and one is another antigen. That's actually given separately, so it's actually a mixed vaccine. It's the conjugate and giving the protein together. I would have liked to have looked to see what just giving the protein alone would do, but they're not very keen on that. But I mean, you could, that is a possible approach. But there is some variation in those, there is some antigenic variation in some of those proteins as well. So, I mean, we can't just think that proteins will necessarily, maybe this is like antibiotics and things. I mean, it has to be an evolving process, and we just have to keep ahead of the
The hip vaccine dose, you want to make a comment?
The hip vaccine, yes, sorry, but the hip vaccine, the question is really, most developing countries don't have a booster dose. And that seems, there's not much data, I don't think, actually. I mean, there is data from Gambia. I don't know what's happening in Kenya and Malawi. But that may be okay as long as there's still some carriage going on in the community. But as you go on vaccinating more and more children year after year, then it's likely that the carriage will largely disappear. If it disappeared completely, then that wouldn't be a problem. If there is still a bit of carriage and the children are not getting boosted, then you might have a problem. So I think we just have to watch and see what happens. And it might be, if in the Gambia in another 5 years' time there's cases coming back and things, you might say, well, we have to give a booster, and then you might have to do a mass campaign with all children under 5 or something like that.
Yeah, I'm wondering if you could speculate what proportion of bacterial pneumonias do you think could be prevented with an effective influenza vaccine?
I think that would depend on your population that you were looking at, and it may depend on what influenza vaccine you use and what's happening at that time and so on and things.
Assuming it's an effective one.
Yes, but I think it is. We have to be very careful. I mean, Professor Klugman would say this was a major cause of deaths in 1918. It doesn't mean that that's going to happen this time. Or I don't know, Amy Ruth, do you agree with that? I don't think we can tell really.
Well, I think the missing piece is we don't know enough about the viral bacterial interaction. So the primary influenza deaths, but then are there bacterial pneumonia deaths that could be averted?
I'm sure there's some,
yes.
but it's what that proportion.
Right.
So
The reason for asking that question is when we try to do etiologic studies, and if we find a pneumococcus in a patient, does that mean that pneumococcus really was the cause, or was it the preceding influenza?
No, I think that is an issue. I think you would save some patients. I mean, if the epidemiologists show you get increases in bacterial pneumonia waves following after waves of influenza and so on. So, I mean, I think there definitely is a relationship there, but it's really how close that is and whether it always happens, and it depends on which influenza virus. Maybe.
Jim.
Can you talk a little bit about any new data that you might have from the Gambia about serotype replacement post-vaccine?
I mean, it was only so one year surveillance data was set up before the vaccine was introduced. It was only introduced in August, so we haven't got anything. But in that vaccination introduction year, serotypes 1 and 5, which had always been very common in the Gambia, were the commonest isolates, which will not be, because this is Prevnar, which will not be prevented. So I disagree with that. Oren and I have had arguments, but I would not have introduced Prevnar into the Gambia. I would have waited for another year until I could have had one of the vaccines that had the 1 and the 5 in it. But we'll see. But I mean, if 1 and 5 are causing all the disease and you introduce Prevnar, you're not going to see an impact.
Neil.
Are you an optimist or pessimist? In the last decade, we've really seen a great deal of advance with regard to prevention of diseases. Yesterday we talked about malaria, now we're seeing advances with pneumonia. But is it going to be sustainable, and where do you think we will be a decade from now?
I think as long as if you think of a country like Niger, it is a very poor country. It has very few resources. It's difficult to see that changing and acquiring resources or requiring new sources. Well, it does have some uranium, and maybe that will be very important. But I mean, you can't see that socially changing a lot. So these measures all cost money, and as we were talking a bit earlier, as we go on further down the line, they tend to cost a bit more money. Pneumococcal vaccines are more expensive than measles vaccines. A sort of chlamydia vaccine or something will be more expensive than that. So it's going to depend on the outside funding, I mean, in one way or another to do that. If that is sustained, then I don't see why we shouldn't sustain these successes. We never, I mean, we're going to have to keep changing, and we can't just stop. I mean, there will be serotype replacement, antibiotic replacement, new organisms will come up that we hadn't thought of, and so on. I mean, it will need that, but as long as the money's coming to go into research, to keep the sort of ongoing process, and is there to pay for the vaccines or to pay for the bed nets, then we'll be okay. And these are small sums. I mean, you heard yesterday, you know, to contain malaria in Africa to a really high level is £2 billion a year. I don't know what the pneumonia control things would be, but I mean, that sort of money. And we're thinking, you know, what's happening to the banks and things. I mean, these are relatively small money. But if that dries up and Niger is left totally to its own resources, we'll go back to what was happening 20 years ago.
Peter.
Brian, I've read a number of places the concern about a lot of the pneumonias having a relationship to the indoor cooking, the city fires, and the possibility that provision of clean burning, inexpensive cook stoves may help a lot. Do you have an impression on that?
Yeah, I mean, we did look in the Gambia, and it's a big you do sort of classical case control studies. It's a big risk factor, and it's the mothers carrying the baby into the kitchen on her back, so that in the Gambian situation, there's an outside cookhouse, and then she takes the small baby in when she's cooking, and that's a big risk factor. I mean, in other places, the social, like in Nepal and things, I think that the other situations are different. But I think there's little doubt that that's so. And there is one study from Guatemala when they did an intervention study using improved cooking stoves, and they got some effect. I don't think it's still not properly published. No, I mean, so it's difficult, but the story, and it didn't work against RSV. I think, is that right? I think it had some impact on pneumonia overall, but didn't work against RSV. That was the last I heard, but it's still not published. And as far as I know, that is the only controlled study to do that. So I agree. I mean, that's another area, and in certain parts of the world, that's probably a very important risk factor.
I have a question.
Yes.
Sorry. I'll come back to you, Brenda. Given what you said about the long lead time from vaccine development to implementation, do you think that there are vaccines that we should be working on right now for other pathogens, or do you think we should wait for some of these newer etiology studies before we make those decisions?
I think Staphylococcus probably, there are good reasons, sort of global reasons for doing that, and that may get a higher priority. So, some people will not know that actually in Bassi, in that way I showed you the floods, in that area, when we were doing in the community blood culture studies to try and find out what the cause of bacterial septicemia were, that the commonest organism was not the pneumococcus, it was non-typhoidal salmonella infection. And that's been found in many other parts of Africa as well. And that's probably always been there. The things that were driving that were malaria and HIV. And you know, we're probably not going to get rid of HIV quickly. And so like in Malawi, that's a really important cause of pneumonia, meningitis, septicemia. And the Novartis Institute in Siena, which is their sort of spin-off from Novartis, I think they're taking that as their first candidate vaccine. I mean, a very interesting thing is that's happened in Bassi, that as malaria has gone from the Gambia, the non-typhoidal salmonellas have gone. So when we were doing this 1 year surveillance before starting the vaccine trial, in the same community, the rate has gone down about 80%. And I mean, that could be something to do with natural cycles or something, but it makes it pretty likely that this was actually getting rid of the malaria. But I mean, in Malawi and East Africa, it's HIV is the driver there. So even if you got rid of malaria, you've still got a problem. So I think those are the two that I would
target.
I mean, the virus is the influenza and RSV, but the next two bacteria is staph. And I think, and then probably after that, unless something very interesting comes up in the new etiology studies that we don't know about, then that may be as far as we can go with the vaccines.
Brenda.
Sorry to do this, but just, I'm just curious to, with all this talk about climate change and the weather, how much of a factor, particularly across the meningitis belt, that the weather is, I mean, it is a seasonal thing,
No, I mean, we don't quite know yet what is going to happen, but I was in Burkina Faso about 6 weeks ago in Ouagadougou, and they had the heaviest rains that people there said they'd ever seen. Came in one day in the rainy season. Now, is this a sign of instability there? In Kenya, it hasn't rained for 3 years in parts of Kenya. So maybe we are seeing in Africa these, I mean, the seasonal trends and things were always there, but they're becoming more exaggerated. And if that happens, we will get problems. I mean, you'll get malaria in areas if you have where there wasn't a lot of rain normally, and you get floods and pools afterwards and so on and things. So I think it will have an impact, but it's not exactly clear what that's going to be.
Thank you very much, Brian.
Okay. Welcome.
So next on our agenda, we have a panel discussion. We're very lucky to have Brenda Wilson with us today, NPR Science and Health correspondent, and also lucky to have 5 faculty members who are joining our panel: Kate O'Brien, Derek Cummings, Bill Moss, Damian Walker, and Andy Pekosh. They're all going to come up and take their seats, and I know, Brenda, you're going to come up to the podium.
Just a few quick words about myself. This is perhaps where the British and Americans differ. Americans never tire of talking about themselves. No, that's not quite true. But anyway, I met Dr. Greenwood right before I went off actually to observe immunizations in Africa. And it was he essentially just directed me to go observe, that perhaps one of the best ways that I could, for example, learn about malaria, because it's very interesting. You can hear descriptions of a disease. You can hear the numbers and have people describe the consequences of it, but it's never quite like being in the Delta and having mothers bring in limp children and having doctors rushing around triaging children, who've been brought in, and mothers who just show up because they hear someone's going to be there in places where no one has been for weeks and months at a time. And at the same time to then travel to northern Nigeria, where they were just beginning to restart a polio immunization campaign. And at the time here in the United States, the big discussion was that rumors had been started that the vaccine contained HIV, and so people shouldn't take it, and that was part of the reason that Nigeria had stopped the campaign. And then you get there and you discover just a whole multitude of reasons, namely that they've got other priorities, including meningitis and measles, and so why are you bringing us a polio vaccine? They've got other concerns. Their children are dying of many things, and perhaps international organizations have, with all good intentions, other priorities, but they may not always address the concerns of the people themselves. I thought that perhaps the best way for our panel to help understand some of the things that Dr. Greenwood has already spoken to us about is to tell us just how, why don't we use that word, interface with all of this, how they come at this. And for example, we could start with Kate, and she could tell us, for example, I think we sometimes forget that we have had to deal with some of these issues here in the United States, and that she's worked with Indian groups here in North America dealing with some of these same issues. Or
however she would like to address the issues. And then each of them, if they could just tell us a little bit about how they come at this subject from their own perspective, whether it is in sort of conducting surveillance, sort of costing out or determining how much it would cost to do some of the things that is suggested that we do or recommended that we do, that we need to do, looking at it epidemiologically. Is it possible to get it under some of the diseases under control through immunization? Is this practical? Is this realistic? Given the competition and the increasing demands being made by people in this country who are very concerned by a pending potential epidemic. I mean, we don't quite know what's going to happen. We've been told that we are heading for one this winter. So with all of our sort of inward focus, what's the likelihood we're going to get people to also be willing to embrace the larger world? So if we could perhaps start with Kate, and she can...
Okay, I'll start.
Kate
So
Wilson.
I'm
Yeah.
Kate O'Brien. I know.
Kate O'Brien, I'm sorry.
And my area of work has mostly been on clinical trials, large-scale field-based vaccine trials among American Indians who have a disproportionate burden of respiratory disease than the general U.S. population. And I think where sort of our interests in the Center for American Indian Health intersect with some of the topics that Brian has raised today is certainly on the science side, where vaccines behave differently in different populations and sometimes in unexpected ways. And clearly in those settings where reproductive rates are high, burden of disease is high, transmission rates are high, we may have a different observation of how a vaccine can effectively reduce disease compared with settings where the bar for the vaccine to jump maybe isn't quite as high. I think where my interest also has been migrating a little bit over time, and I think so much of what you talked about today, Brian, is really this fulcrum of where the science of vaccines is so important and takes so much time to achieve answers so that we can confidently, as the technical community, go to policymakers with interventions that we know will work if used. But there's a whole life cycle of implementation and decisions on implementation that has to be taken, and there are real complexities of market forces, vaccine tendering processes, supply, finance, market segmentation, and I think there's a really important role for the technical community to play in that communication across into those policy arenas. So I think that's where we're going to hit some of the wall here in terms of effective strategies, that I think the question is really out there, whether or not we can effectively reduce disease through their use.
All right, and I believe Bill Moss, who is a pediatrician who has worked with children who have both had to deal with both HIV and perhaps dealing with measles, which I don't think many of us here in the United States have in many years have had to deal with children with measles or that sort of thing. And at a time when we're talking about getting vaccines to pneumococcal vaccines to children, many of those children, particularly in Africa, are also going to be HIV positive. A great percentage of those children that Kate identified in her study were also, confronted with an epidemic of HIV there.
Thank you, Brenda. So I'm Bill Moss. I'm from the Department of Epidemiology, and a lot of my research interest over the past 10 years has been trying to understand the interactions between measles, measles virus transmission, measles vaccination, and HIV-infected populations. And I'll just pick up on 2 points that Dr. Greenwood made. First, I was pleased to hear him say that the measles vaccine was a very important vaccine for preventing pneumonia. We don't often put it in that context, but many children with measles die of subsequent bacterial pneumonia, including Streptococcus pneumoniae and Haemophilus influenza. And I think we're at a very critical time globally in terms of measles control. And it reflects partly the double-edged sword of a successful vaccination program, because there have been remarkable reductions in measles incidence and mortality, particularly in sub-Saharan Africa. But this can lead to a complacency about a disease. I know the Measles Vaccine Initiative program is short of funds in the coming year, and I think that partly reflects the fact that there's been enormous success. Brenda mentioned the problems with vaccine coverage, and a lot of the success with measles vaccine, with the measles vaccine program, has been through mass campaigns, and that's because of some of the significant limitations in the primary healthcare system and routine vaccine delivery in getting high enough measles vaccine coverage to actually make an impact. And so one of the big challenges, as has been pointed out, in turning these efficacious vaccines into effective vaccines is going to be having high coverage in sub-Saharan Africa. The other point I'll pick up that Brian alluded to is the impact of HIV infection. And certainly there are a number of countries in sub-Saharan Africa that have very high prevalence of HIV. And as Brian mentioned, the burden of disease is much greater in these populations. They tend to, HIV-infected persons are much more likely, at much greater risk of getting severe pneumonia, very severe pneumonia, being hospitalized. A lot of the key studies have been done by Sabir Mahdi and his group in South Africa, and they think that half of all children being hospitalized for pneumonia in South Africa are co-infected with HIV. There are a lot of interesting interactions between HIV and these diseases and these vaccine responses, and in general, HIV-infected children tend to have poorer responses, lose immunity after vaccination, and so this is going to be a challenging population to maintain protection in, even with effective vaccines.
All right. Okay. Now we're going to figure out how we can sort of track essentially what's going on. Because we can't always be there. We're just going to have to sort of use what information we have to get from one point to the next. That's about a really rude, crude description of modeling that Derek Cummings will do a much better job, I hope, of explaining how we're going to be able to track what's going to happen using modeling, because that's what he does.
All right, thank you. So my research interests are in a number of pathogens and transmission dynamics of influenza, measles, and dengue. And I'm using models to try and understand the population level dynamics of these pathogens, particularly interested in sort of natural cycles of incidence of endemic diseases. And in terms of vaccines, models provide a tool to try and project what the impact at a population level a new vaccine might have, but also to try and optimize the delivery of vaccines. So for measles vaccines, as Bill has said, we've been very successful, but now we're getting to the point where it's very difficult to make further gains in many locations. But yet measles still persists. And so I've done a fair bit of work looking at vaccine schedules and looking at supplemental immunization activities and how they might be optimized to drive transmission to the lowest levels possible. Models can also be used to try and assess, working on a project funded by the Gates Foundation, to try and assess the portfolio of investments in new vaccines and new technologies to deliver those vaccines. What will the impact of those new technologies be that might be available in 10 to 15 years? What are the interactions between them? And which ones might have the best shot at actually having the greatest impact on a number of pathogens? And so my work on that project, it involves both measles and dengue, and looking at new delivery technologies for measles, and then what the impact of a dengue vaccine might be. And finally, really to get at a model that's worth anything, you really need to do the science to figure out how the community dynamics of transmission. And so models are really, I think of as a tool to sort of put together your hypotheses about how these pathogens are transmitted within the community, and to test those hypotheses. And so I do a bit of empirical work on influenza in southern China to try and understand the community dynamics of influenza and the transmission in rural areas compared to urban areas. And I think many pathogens that cause pneumonia and influenza, this is certainly true, it's thought of as such a pervasive risk details of transmission dynamics are rarely really explored to try and understand chains of transmission, try and understand really the infection pressures that individuals experience and predictors of those pressures. And so I think there's lots of empirical work to be done to try and understand the dynamics of these pathogens in communities.
Okay, thank you. And now I'm sure everybody is wondering, having listened to Dr. Greenwood, that we may be possibly faced with the threat of not only swine flu or H1N1 epidemic, but also at the same time getting hit with pneumonia. And the question is, you know, how do you deal with that? I mean, there's some suggestion, I think, from the Centers for Disease Control that people who are at risk of pneumonia might want to get not only a vaccine, H1N1 vaccine, but also a vaccine for penicillin. Perhaps Andy Pekos can tell us how, you know, we're going to deal with this possible threat and how great a threat, or, you know, when you're faced with those sort of concerns.
Thanks. So yeah, I'm Andy Pekos. I'm Associate Professor of Molecular Microbiology and Immunology here at Johns Hopkins, and I really fall on probably far end of the spectrum here in terms of areas of research interest. We study respiratory viruses, particularly influenza, and we really look at the basic mechanisms of how viruses do what they do, infect cells, assemble, and cause disease. And in that process, we really have sort of two overriding goals in mind. And one is by understanding how viruses, you know, do what they do and cause disease, we can get our handle on one dial of the virus, which is we can find ways to attenuate the virus, to slow down its replication, or ideally limit the aspects of virus replication that cause disease while maintaining aspects that allow the virus to present its protein to the host and therefore generate immunity. In that way, we can hopefully find a next generation of virus vaccines, which are even better in terms of inducing immunity, but yet are safer in terms of their ability to cause disease. And to do that, we do a lot of small animal model work, a lot of tissue culture work, establishing systems that we can manipulate in the laboratory. A second aspect of this, though, really comes in when we see an emerging infection like H1N1 right now, and we see, you know, unique portions of the population suffering either large amounts of disease, or in some cases, limited amounts of disease. And what's been really fascinating for me over the past few months is to try to think about these problems from a basic science standpoint and ask whether or not there are ways that we can go to the laboratory and set up systems where we can perhaps reproduce some of these things we're seeing in the general population, find out mechanistic ways of what's going on in terms of why the things being caused, and perhaps then feed back and relate back to some of the other people who are more on the front lines of dealing with this disease and provide them with additional information that might help them deal with some of these unique outbreaks in different populations.
Okay, thank you. And now, Mr. Walker, I mean, the really big question that's facing, I suppose, the West is how much it's willing to share any of what it's got, especially if it needs it. And right now we're, you know, seeing a pull and tug even in the United States because of people's concerns about vaccines here. Do we add something to a vaccine so it'll go further so that we can share it with the rest of the world? Or do we make a vaccine that Americans feel comfortable with that we won't be able to share as much of it with? Now, again, another crude description of, you know, one of our more recent dilemmas that we were faced with. But the whole question of equity, how much do we have? Do we have enough to go around? I mean, we've just about eliminated pneumonia and Haemophilus influenza type B in the United States and the West and European countries practically. But we don't seem to be getting vaccines to developing countries where they need them right now, where the problem exists.
Thanks very much, Brenda. Good afternoon. My name is Damien Walker. I'm a fellow Brit, and I did my PhD at the London School of Hygiene and Tropical Medicine, so it's very nice to see Brian here today. Yeah, so much of my research really focuses on the cost effectiveness of childhood vaccines and also on financing issues. And I think one of the points that Brian highlighted in his presentation was that once we have established that these vaccines do appear to be highly cost effective, there is a tension with their affordability. And I think we really need to address that. Brian also spoke to the fact that we're no longer talking about pennies per dose, we're now talking about dollars per dose. So we do really need to change how we operate. I think business as usual is not going to suffice in terms of financing these vaccines. Having said that, there are a number of innovations that are taking place, and I think the dismal science of economics has actually been quite helpful in this regard. Brian spoke about the advanced market commitments. We can speak about that a little bit more if you'd like. There's also IFIM, which is the International Finance Facility for Immunisation, which was, I'm proud to say, the brainchild of Gordon Brown as well, and the government in the UK. So I think things are beginning to change there, but I do also want to just talk about what affordable vaccines means. And I think we really could be and should be asking countries in Africa to be spending more on healthcare and specifically on vaccines. Globally, governments spend about 18% of their expenditure on healthcare. However, in Africa, that's about half that, about 8 or 9%. So they really seem to be investing less than many other parts of the world. And also, up until now, only about 50% of the costs of running their immunisation programs have been paid by their governments. So I think there's a concern there. Equally, I'd say, though, I think governments in rich countries have been falling well short of the targets that they have met, have specified themselves. 0.7% of GDP should be going to overseas aid. Just to speak about the US and the UK briefly, in the US, unfortunately it's only about 0.18% at the moment. The UK is doing a little bit better, but it's only about 0.4%. So I think both countries in Africa, the governments themselves, should and can be spending more, and the same is true for donors as well.